I think the kind of relationship between doctors and the public has changed a lot since the pandemic. I think this is one of those things that, yes, a lot of people have been quite negative about, to be honest. And I think that relationship does need to be rebuilt.
Resident doctors in England have accepted the government's pay offer, ending 3 years of industrial action. The offer also includes more training jobs for newly qualified doctors, faster pay progression and the state covering exam fees. Let's talk to our resident GP, Dr. Rachel Ward. Hello, Rachel.
Good afternoon.
Now, we've talked a lot about this in the past. Now it has come to a deal. Do you think it's a fair deal?
I think there's some really key parts to the deal, which I think are really important going forward. So, we have discussed the lack of training jobs in the past, and there is a commitment to, I think it's 4,500 more training jobs. We cannot have a situation where we're training expensive doctors and then there is a stop in their career because they can't get a job when we need doctors down the line. So that makes sense. I think also things like contribution to exam fees. Professional examinations are incredibly expensive in medicine, and it's something that your employer wants you to have to progress. So I think that kind of thing is also very positive. So yeah, some really positive changes.
Do you think all of it was worth it? Do you think that some severe damage has been done between potential patients and doctors?
Yeah, I think overall, and I don't think it's just to do with the strikes, I think the kind of relationship between doctors and the public has changed a lot since the pandemic. I think this is one of those things that, yes, a lot of people have been quite negative about, to be honest. And I think that relationship does need to be rebuilt. And hopefully now that, that is settled, that doctors do need to definitely work on that as well.
Let's definitely talk about this report into NHS maternity services by Baroness Amos, published today. Do you witness any similar kind of difficulties as a GP between parts of the NHS that just have friction between them? This is what has clearly been identified in Baroness Amos's report, the difficulty that midwives and doctors can often have with each other.
Yes, I think, being really honest, I think it is something that we see throughout the medical profession. And I would say that there is a reputation for these kind of relationship challenges. They do exist in some specialties more than others, to be honest. And that's something which has existed for a long time, in the same way that, we've talked before about the misogyny and the sexism, which still very much exists in the surgical world. And I think we as a profession have been very poor at stamping this behaviour out and getting over these difficult relationships and working together professionally.
And I mean, you know doctors, nurses, midwives. What will they all be saying to each other about this report, and actually about the Ockenden report last week as well? Is it a very different conversation to the one that maybe you and I would have about these reports?
I think overall the message has to be, and the discussion has to focus on how families and babies have been impacted by poor care. That is the bottom line, and I think anyone who is not having that conversation really needs to be reflecting on their own practice. But of course, there are things, whenever you have a report, it can be very easy to say that things need to be changed, things need to be improved. But when you're on the ground and you're understanding some of the challenges, it can feel difficult to think, well, how is that going to happen? How is that going to be put into place? So I think one of the interesting examples that came out in the Times review today was that it said that you need to basically have your most senior consultants present 24/7. And I think any consultant working in maternity would agree that, yes, senior cover is the most sensible and safest. However, if you remove consultants from the daytime to the middle of the night care, you need to understand that there's going to be a knock-on effect elsewhere. There's going to be longer time for clinics. You're going to have less consultant cover with complex birth decisions in the day. So we need to understand that there's always knock-on effects in a in a pressured system. And I think that's what people think.
Sure. I mean, there'll be lots of people listening who'll just say, well, why can't we just have more consultant anaesthetists and obstetricians? If the problem is that they're going to be spread too thinly, surely the solution is get more of them.
Yes, and again, it comes back to that concept that we're training all of these doctors and then they can't get specialist training jobs. So again, I guess a positive thing that has come out of these 4,500 increased training jobs per year going into specialist training and producing more consultants out the other end. But that takes time, and it's also very, very expensive. And so it's never about, nobody thinking it's a good idea. It always, unfortunately, comes down to pound, shilling of pence of how many people you can employ in a department.
As you see so many women when they first come to you and say that they're pregnant, and I presume, that they still do, you probably don't see them again until they come back into the surgery with a baby, or do you?
Right. So one thing that's changed over my time as a GP is that all antenatal care, it used to be split between general practice and maternity services. And now, certainly where I work, it's all carried out in maternity services. And I personally think that is a shame because I think we lose that continuity with our patients. But, there were decisions made that actually you need people who are upskilled in that area all the time doing it. But again, it's one of those things that, yes, I think having a baby is obviously such a big part of your life and your health, but you may actually have a lot of other health issues going on at the same time that your GP is so integral of. So there's this gap then that you don't see your patients while they're pregnant, and then you kind of, are reunited at the end of it. So there's so many things that I think could be improved.
Do you know what? I think that's a mistake. I think it's great to be able to carry on seeing the same person during your pregnancy. I mean, it's a time when so many other health issues can bubble up. The fact that you're packed off to maternity services to meet a whole new team. Most women don't see the same midwife from 1 month to the next. I think that is all part of the problem, actually, Rachel. We will talk more about that, I'm sure. We do need to talk about scabies before we let you go this afternoon. Now, we got an email from a listener whose grandson came back from university with a bad case of scabies. And he's not the only one. The doctor that he went to see, and will retain everybody's anonymity here, said that actually their practice was seeing students with scabies all the time. There was quite an outbreak in that city.
Yeah, so I would say over the last 12 months, I have seen loads of scabies. I don't service a kind of university campus, so I can't comment on the university thing, but it absolutely makes sense for it to be in university populations. But we are seeing definitely an increase, and statistics would show as well that there has been an increase in scabies. So scabies is an infection. It's a mite infection that lives under your skin, and basically you develop a very itchy raised rash, which tends to be much worse at night, and then you kind of start developing little raised red lumps. Now the problem with scabies is that it can actually be quite difficult to diagnose, and so it may be one of those things that people have been to the pharmacy a few times, they may have been to their GP, they may have been diagnosed with something like eczema instead, and so there can be a bit of a delay in treating it. The other difficulty is that it is actually quite difficult to treat. So you have to apply an ointment over your entire body, and you need to keep that on for 12 hours, and you need to repeat it 7 days later. You also need to wash all your bedding, your clothes. It's quite an involved process, and every person in the house has to do it. So in my experience, one of the most common reasons that these infections carry on is that the treatment hasn't been carried out precisely, or doses have been missed, and so the infection just keeps grumbling on in a household.
Right, okay. So I'm thinking out of all of that students, bless them, I mean, they're wonderful creatures and our entire future rests upon them, but I'm thinking that this is just a hotbed for scabies spreading, isn't it?
I think you've hit the nail on the head. I'm not sure they're going to be on the ball with their 6 degree wash of their bedding, etc. So yeah, absolutely.
Right, but also just having to spread some kind of ointment all over you and keep it on for 12 hours. I mean, nobody wants to have to do that, do they? Especially not in a student hall of residence.
No, it's certainly a bit of a faff.
Okay,
yeah.
Can you offer advice that parents can pass on to their kids of how not to get it? I mean, is it just about keeping very, very hygienic in a communal environment? Is there a spray that you could use? What could people do?
Unfortunately not. So scabies is one of those things that is passed pretty easily when living in close quarters with people. It's not something that you get from literally one touch of somebody, but kind of close contact for a more prolonged period. It's very easy to spread. So I think it's just all about being aware if your household is coming out with an itchy rash, get it checked out, and then you just need to be meticulous with the treatment, unfortunately.
Okay, no petting. It's always lovely to talk to you, Rachel. Thank you very much indeed. Rachel is our resident GP.